Hello everyone, this is Group 2. Today we will introduce cardiac failure. We choose some transcultural nursing and global and local terms and issue in the care management. Now let's this case. A female 50 years old American was hospitalized with fever, cough, shortness of breath for 1 week. Psychological information, American English speaking, athlete master's degree, high class. Eating habits for Western food like steak, cheese do not accept Chinese food. The patient has a strong sense of time and stresses efficiency, and accompanied emotional ambition and independence. The history of present illness: the patient developed fever after a cold 1 week ago, with the highest body temperature reaching 38.3, accompanied by cough, yellow sputum, shortness of breath during activities, inability to lie supine at night without edema of lower limbs, and decreased urine output. Before the onset of the disease, the patient had limited physical activity and shortness of breath during brisk walking, but had no chest pain, back pain, and upper limb radiation pain. Past history: the patient had a history of hypertension for more than 10 years, and the blood pressure control was satisfactory after oral antihypertensive drug treatment. The patient denied a history of diabetes and heart disease. In transcultural nursing, we have 4 points to introduce: nursing assessment, nursing diagnosis, care planning and implementation, effect evaluation. In transcultural nursing, we use sunrise model. According to this model, our nursing assessment is the first level of assessment. Work with cultural and social structure content. Work with materialized religion, belief in Islam, technology, deputy general manager of foreign enterprise, kinship, alone in China without family members, outlook on life and values, advocate independence and efficient, economic level, high income, education, master's degree, language, English, only a little Chinese. The second level of evaluation: several object, individual, health structure, admitted due to fever, cough, and shortness of breath. During hospitalization, vital signs are abnormal body temperature evaluated, blood pressure evaluated, and pulse rate evaluated. Expectation of care still. Likes to be independent and doesn't want others to take care of her too much. Level 3. Assessment health system. Civil health system emphasis on self-care and self-reliance. Professional health system consists of doctors and other health care personnel. Nursing system: the nurse help and educate are essential during the patient's hospitalization.
Hello everyone, I speak nursing diagnosis. The commonest and the difference transcultural nursing. Common care is to reduce breathing difficulties, reduce body temperature, control blood pressure. B. Difference. Different nationalities lead to a certain degree of language communication barriers. Patients with different culture backgrounds have special requirements for medical treatment and care. Patients with strong sense of independence do not want to rely on others. Next, the main nursing problems during a patient's hospitalization. This dyspnea is associated with congestion in the lungs, decreased urine output is associated with left heart failure, and decreased cardiac ejection volume fever associated with exposure to wind and cold. Anxiety associated with change in healthy studied and raw functioning, change in environment and daily life and language communication disorders, language barriers and related to culture and linguistic difference. Lack of knowledge is related to poor communication of information due to culture and linguistic difference. Non cooperation is associated with patient's culture background and healthy beliefs. Three parts is care planning and Three part is care planning and implementation. First one, we will all eliminate dyspnea. Second, body temperature to restore. 3. Relieve cough. 4. Reduce anxiety. 5. Eliminate language communication barriers. 6. Continue the knowledge education of related diseases. 7. Provide a healthy lifestyle. Last, establish a good nurse-patient relationship. 4 is affect evolution. 1. Whether the disease is in remission. 2. Whether anxiety can be alleviated or eliminated. 3. Whether the poor communication has been improved. 4. Whether the care provided is consistent with the patient's culture care expectations.
Global and local trends and issues in the care management. Globally, 17 to 45% of heart failure patients die within 1 year after admission, and most patients die within 5 years after admission. However, approximately 2 to 17% of patients die of heart failure during hospitalization, and those who are treated in the outpatient clinic have better survival rates. Despite improvements in care over the past 20 years, patients with heart failure still have a poor outlook with worse survival rates than those with bowel, breast, or prostate cancer. In North America and Europe, there are very few heart failure patients aged 50 years or younger, and more than 80% are 65 years or older. In countries with aging populations, the number of heart failure patients is expected to increase. In particular, Japan is the country with the fastest population aging of all economically developed countries. In the United States, 5.8 million people suffered from heart failure in 2012, and it is expected to increase to 8.5 million by 2030. In economically developing regions, such as parts of Latin America and Asia, the number of patients with heart failure is also increasing. In many parts of the world, infection is still a common cause of heart failure, which can occur at any age. In sub-Saharan Africa, heart failure is not a disease of the elderly, where half of the patients are hospitalized, aged 55 or younger. Patients in the Asia-Pacific region tend to be younger than those in the Western region. Rheumatic fever caused by preventable bacterial infections is a prominent cause of heart failure in Africa, Asia, Australia, and Latin America. An HIV infection is also a major contributor to heart-related diseases worldwide. In Latin America, where Chagas disease is common, almost half of heart failure cases are a direct result of this preventable parasitic infection. In tropical regions, endocardial fibrosis Davis disease has historically been a common cause of heart failure. This chart is hospitalization rates and numbers of patients with heart failure as the primary diagnosis in countries worldwide. HF is the number of hospitalizations whose main diagnosis is heart failure. The total number of AHF 2010, the most recent year for which both data sets are available. HF total, the proportion of the number of hospitalizations with heart failure as the main diagnosis to the total number of hospitalizations. On a global scale, the increasing burden of heart failure is causing damage to society, especially to patients, caregivers, and healthcare systems. As a main diagnosis, heart failure accounts for about 1 to 4% of all hospitalizations in economically developed countries. The economic cost of caring for patients with heart failure is high, accounting for about 1 to 3% of total medical expenditures in North America, Western Europe, and Latin America. In contrast, the total global expenditure on all medical products and services in 2010 was $6.5 trillion. In Germany, the total medical costs caused by heart failure in 2006 were estimated at 2.9 billion euros. This figure includes expenses for hospitalization, outpatient and daily services, as well as medicines, equipment, and other medical products. In the United States, the total cost of hospitals, doctors' prescriptions, and family health care related to heart failure in 2012 was estimated at $20.9 billion United States dollars and is expected to increase to $53.1 billion United States dollars by 2030. Globally, the average length of hospital stay is about 5 to 10 days. In the past 2 decades, hospital stays in Europe, North America, and Australia have become shorter. However, in Europe and North America, about a quarter of heart failure patients are readmitted to the hospital within a month, and up to 2/3 can be admitted within a year, usually because of recurrence of heart failure. People who have symptoms of worsening or recurring heart failure at the time of readmission are most likely to have end-stage failure. And the emotional, physical, and economic costs of carers who care for family members with heart failure are also high.
Hi, I'm Leah. Next, I will introduce about the future direction of care, urgent unmet need. About unmet needs at all stages of the heart failure. The first is about prevention. It limits infection. Next, diagnosed. Raise public and professional awareness of syndrome. Provide equality of access to diagnostic tools. Research new diagnostic test, develop the better measures of the care quality, promotes compliance with clinical guidance about the treatment, research the new treatment, and provide the quality, optimize the transition to long-term management. So about long-term management to research remote monitoring and communities clinics. The next, the future direction of treatment. In the future, the focus to prevent and treat the rapidly worsening the symptom of the acute heart failure and reduce mortality from the heart failure. Combine the treatment of the heart failure and other diseases in the old people. Health care for women with heart failure during the pregnancy. The cost of the caring for individual patients with heart failure has increased significantly, and the more affordable the treatment will be developed in the future. 3 components of the patient's care: maintenance, monitoring, and management. In the future, we'll have the new strategy for long-term monitoring and management of out of the hospital's patients can improve the quality of life and survival, reduce numbers and the frequency of readmission, and educate and support heart failure patient family activity participate in the management of long-term care. So, in the future, we have the careful consideration educational media about the short video, text message, and the social media can be used to convey message. Nursing's pathway. Compliance can be encouraged through the use of the care pathways, which are systematic, guideline-based plan to care for the specific patient at a specific time. The nursing pathway has been shown to improve survival in patients with heart failure, but there is no established pathway that is suitable for use in all the medical organizations. So, that is the focus on improving diagnosed treatment and long-term management to improve survival. So in the future, the hospital will implement the reward and punishing nursing staff about encouragement to improve the quality of the care, measures performance, and encourage nurses to improve the care plan, make the best plan suited to their patient. Punishment aim at reducing preventable the patient readmission. There is concern that these penalties may failure penalize the hospital with higher survival rate, and that actually reflect difference in post-discharge community care standards rather than in hospital care, and also provide incentive for good performance outside the hospital.
In this part, we will discuss the issues and challenges in the management of care for heart failure and the response to global trends.
First of all, let's discuss the problems and challenges in 4 aspects. The effects of frailty on prescribing bang, sepsis, the issues of the impact on heart failure, winning hearts and minds, and pulmonary hypertension. Weakness refers to a series of events that occur when the body loses its ability to cope with normal disruptions. The damage may be physical, psychological, or social. Frailty patients have a poorer physician, or frequently spend more time in hospital and recover longer. Unfortunately, debilitation of heart failure. Little is known about the debilitation of heart failure. However, the gold standard treatment for frailty is a comprehensive assessment of aging, which may be a further area of development in heart failure services.
Sepsis in patients with heart failure can have serious consequences, or death. Sepsis is a continuum, which begins as a clinical syndrome in which the body's immune and clotting systems are activated when an infection occurs in the blood. This can develop into septic shock, a life-threatening disease characterized by low blood pressure despite severe reheating, major organ dysfunction and sepsis. There is also an increased risk of fluid overload after sepsis treatment.
Pulmonary hypertension is a common complication of left heart disease resulting in more severe symptoms and worse exercise tolerance, while having a negative impact on interventions and outcome. The pulmonary circulation is often overlooked in the assessment and management of patients presenting with heart failure symptoms, so it is helpful to look at the right ventricular systolic pressure (RVSP) on the patient's echocardiogram. People living with heart failure may experience improved outcomes if they engage with the self-management of their symptoms and are concordant with their medication. For those with getting illness, addiction or anti-social behavior, this may not be straightforward. Addiction is a particular concern in younger men, with around 4% of men being drug dependent. Alcohol causes around 1 million admissions a year and is responsible for just under 7,000 deaths per year. The practicalities of caring for someone with heart failure and mental health issues can be difficult. They are often non-compel.
Homeless, and have no access to a GP, they may have no family support or their personality traits may prove a challenge. The expanded basis of evidence from clinical trials remains limited in application to practice. Although the term practice in relation to medicine has often been invoked as the repetition of, and this is the last of the definitions of practice. The first is the actual application of a plan or method, as opposed to the theories to it, derived from the Greek praktikos, meaning concerned with action, from which also comes the adjective practical. Practical decisions must be made every day in the care of individual patients. Innovation of heart failure nursing management. Heart failure specialist nurse (HFSN) services are now well established in many areas of the UK, or some gaps still remain in the service provision and staffing levels in certain localities. A UK study which was the concise that Army LED interventions at optimizing bleeding and improving self-management not only reduced readmission rates 5 but reduced in savings that offset the cost of the heart failure nurse service.
The HF Primary Care Initiative is an innovative community and home-based HF program led by HFNS. The Big Lottery funded 76 HFSN posts in 26 NHS primary care and administered the funds, managed and supported nurses and helped shape the roles and services by providing professional development. A key recommendation was that services should be part of an integrated pathway of care, from diagnosis, through ASHMS to stabilization and deterioration, including supportive and palliative care for the dying patient. The government wants the NHS to promote integration. The community-based model of heart failure care focuses on cardiac rehabilitation and arrhythmia care. An external evaluation is currently under study way, focusing on 4 main outcomes: improving the quality of service, patient quality of life, identifying patient care needs, and implementing preventive measures.
Increasing numbers of people living with HF and other long-term conditions have prompted innovative ways to manage ever-expanding caseloads. However, despite more than 20 years of research in this area, the most recent systematic review found inconclusive evidence that telehealth is more effective than usual care in managing patients with HF.
Our screening is over. Thank you for watching.